pleasure of welcoming today to the College Forum Doctors Dana Lerman and Tracy Zivin-Tutela. Both have been working with us along with their teams since last spring in March when we began the process of looking at what the COVID pandemic was doing to our community and the return to campus. Now they come to us today to talk about vaccinations and that process and debunking myths and providing information. We also have and I must say that also both doctors have ties to the New York community, having either grown up here or practiced medicine or educated in the New York community, including at Mount Sinai, at Columbia, at St. Luke's. So we welcome them back to New York City. We also have Peter McHugh, and Pete is a member of the Manhattan College family, but in this capacity, he is also what we call the communications director for the One Manhattan Return to Campus process. So next you'll hear from the doctors, and then Pete will moderate the questions and answers that have been previously submitted. So thank you, and again, welcome.
Thanks, Tamara, and welcome Doctors Lerman and Zivin-Tutela. We look forward to your presentation. Feel free to begin when ready.
Thanks, Pete. Thank you, Tamara, for introducing us both. I'm Dr. Lerman, and I'm going to chat briefly with you guys about COVID-19, just some basic information most of us already know, and also debunking some critical vaccine myths. So first, I know we already introduced Dr. Zivin-Tutela, but we've been working together since the beginning of the pandemic. And the two of us actually went out together to Los Alamitos, California in January, I believe it was. And this is just a photo from Dr. Chutella on the floors taking care of COVID patients. And this is actually one of the makeshift hospitals in the parking garage that we were often seeing patients in. So besides working with companies and various businesses and schools like Manhattan College, we also are on the ground and have cared for several COVID patients. So I just wanted to kind of briefly talk about where we're at. This is as recent as yesterday, just the stats worldwide. And if you can look at worldwide cases of coronavirus, they're quite staggering, but also the number of deaths, almost 4 million we're approaching worldwide. And then obviously those numbers trail down once you get to the United States and then New York, but also staggering numbers because the United States is one of the leaders in the COVID pandemic in terms of cases and deaths. And New York is obviously, as we all know, one of the epicenters of the disease. So some important facts about COVID-19. Many people, again, know these, but I wanted to highlight some of the more important ones. So COVID-19 is not a virus. COVID-19 is a disease, but it's caused by a virus called SARS-CoV-2. It's highly contagious. It's spread by respiratory droplet and airborne spread, and also by touching infected surfaces. But we really think that is a less likely mode of transmission and more so spread in the air. And we've learned more about this since the beginning of the pandemic, which at that time we actually thought the opposite, which is quite challenging to look back at those recommendations. We know that it spreads beyond 6 feet, and it can spread up to 60 feet, which is something that we recently established out of a paper that I think MIT did. So 6 feet of social distance is an absolute minimum, and we'll talk about why in a little bit. What a lot of people don't know is that COVID can remain suspended in the air for up to 3 hours. So long after an infectious person has left the room, you can have viral particles that are contagious, that are just floating in the air. As we all know, anyone who watches the news or reads the newspapers, we know that many variants have developed, and this is just a mutation. And this is what viruses are supposed to do. They're supposed to mutate so they can survive. And unfortunately, some of the variants that have developed are more contagious and more severe. And notably, the Delta variant that has originally been identified in India is most likely going to become the dominant strain in the United States. So we're looking at about 20% of the cases, the isolates that we're sequencing here in the United States are the Delta variant. Vaccines, we know, are highly effective at preventing symptomatic COVID-19, and they're extremely effective at preventing hospitalization and death from COVID-19. So we don't only give vaccines, we don't give vaccines to completely knock out a virus. It would be very unexpected if we didn't have any cases. We give them so people don't end up in the hospital and don't end up dead. That is the main focus of the vaccination campaign. So this is a picture that many infectious disease physicians know. It's a common picture where you can see someone sneezing or coughing. And these are the respiratory droplets. Those are the larger droplets. But what can also happen and what remains suspended in the air is the aerosol particles. So what's actually happening in those particles is that this is not a real life picture because there are many, many, many more viral particles in each droplet of water or aerosol. But so these little droplets are carrying these viral particles. And that's what can remain suspended in the air and can infect people when it lands in your mucous membranes, which is your mouth, your nose, your eyes. So some other important facts, about 40% of people don't have any symptoms. So that's something important that I think it's really a struggle for people to learn that they have COVID-19 and they're in denial because they don't have any symptoms, but we know that this is common. There are certain people with medical conditions who make them more susceptible to severe disease, meaning hospitalization and potentially death. And those are people with obesity, kidney disease, diabetes, liver disease. There's a laundry list of underlying medical problems that put people at elevated risk. Many people, once they have COVID, do develop a cough or shortness of breath, and loss of taste or smell is highly associated with COVID-19. And about 50% of people have fever. So not everyone has fever with COVID-19. So there are many other symptoms, and we've learned this is another laundry list that's developed from the beginning of the pandemic when we initially just thought it was cough, fever, shortness of breath. Now it has extended to cause rash, stomach pain, sore throat, stuffy nose, COVID toes, COVID tongue. These are all things you can Google images of these, but these are all known to be associated with coronavirus. COVID-19 can also cause issues beyond pneumonia. This is an important thing that we've noticed in the hospital early on. I myself personally have had young people come in blind from COVID. I've had a patient who had a heart attack. I've patient who had a stroke. It can cause kidney failure, put people on dialysis. Even young people with no underlying medical problems, it can cause these issues. So that's something very important to recognize. It does not discriminate. So there's no cure for COVID-19. There are some medicines that people can take that can make them get better faster. So if you were admitted to a hospital, there's a variety of medicines that we can provide to you, and they can be helpful for some patients. So this is actually a photograph from a friend of mine who's at the head of the bed. This is an anesthesiologist, cardiac anesthesia, and they are trying to save the limb of this patient who ended up having, this patient ultimately ended up passing away, but they had a blood clot in their leg from coronavirus, required an amputation. But unfortunately that wasn't enough to save this patient. So I felt that this picture was important just to not only illustrate really what the patients are going through, but what these doctors are going through, because this is not the typical garb that a surgeon or an anesthesiologist would wear in the operating room. So this makes all the surgeries and procedures quite cumbersome and difficult. Not only that, but they put themselves at risk. So status of immunizations across the United States, New York, and worldwide. So about we're approaching 50% of the United States population being fully vaccinated. And fully vaccinated means that it's been at least 14 days from your mRNA, from your second mRNA vaccine dose, or it's been at least 14 days from a Johnson & Johnson dose. So you have to wait 2 weeks from the last dose in the series. New York is above 50%, which is great, but it's nowhere near this this herd immunity that we talked about initially, but it's really not so much spoken about anymore, unfortunately, because it looks like it's a very difficult thing to get to. 10%, around 10% of the global population is fully vaccinated. There are several countries that don't have any access to any vaccinations at all. So I just wanted to kind of briefly talk about what vaccines are available right now. So currently we have 3 that are approved under emergency use authorization. There's no FDA approved COVID vaccine anywhere in the country. So we have the 2 mRNA vaccines, Pfizer and Moderna. Those are the ones that came out first. We have the efficacies listed there. The mRNA vaccines require 2 doses each, and both doses, and I'll go over this a little bit later, are required to get the full efficacy. Pfizer is the only one that's approved for 12 and up. Johnson & Johnson, as we all know, is the one and done vaccine. And each vaccine has a little special note with it. And the mRNA vaccines, we've realized early on, once they were administered to the public, were associated with dermal filler inflammation. A dermal filler is basically something that gets injected into the face, typically for cosmetic reasons, and the patients can get inflammation either at any area where that's injected. That is easily treatable. Patients see a dermatologist. Dermal filler injections are not a contraindication to vaccines. So if you've had dermal filler injections, that doesn't mean that you cannot get a vaccine. Most recently, a lot of us have been hearing about myocarditis, and that has been associated with mRNA vaccines, and I'll talk about that in a little bit. And that's just basically an inflammation of the heart muscle itself. So again, we'll go into detail there. We all know that the Johnson & Johnson vaccine was put on hold briefly in April, I recall, for a little less than 2 weeks while they established if the blood clotting diseases that they were finding in patients were enough to warrant them to take the vaccine off the market. And after rigorous analysis and continued analysis, they've decided that the benefits of this vaccine outweigh the risks. They do have a warning with the vaccine that does suggest that any female patient who's under the age of 50, that they can still get that vaccine, but the risk for them with this blood clotting disease is elevated. However, they can still get this vaccine, but they should seek out alternative vaccines from Pfizer or Moderna. So this is just the dermal fillers. You get some inflammation there, like I showed you before, and some patients actually have to have their dermal fillers removed, and some are treated with steroids. But this is not a complication that will make the vaccine a contraindication. So the Johnson & Johnson vaccine, I think a lot of us in the medical community believe in complete transparency. So I just wanted to share with you, all of the cases of this blood clot. So what is happening actually is the blood is clotting in some places, and the blood platelet count is dropping in the peripheral bloodstream. And I'll show you a picture of what that looks like. So these cases have happened in women less than 50 years old. And it's just something that we should be aware of. But again, this is not taken off the market. These instances are very rare, and it's important that people understand that the benefits really outweigh the risks of this vaccination. So what is this thrombosis with thrombocytopenic syndrome, or TTS? So as you can see, there's a lot of blood cells that are being clotted up in one particular area of the blood vessel. And then in the other areas of the blood vessels and throughout the peripheral bloodstream, the platelets are very low. And so people can have clotting and they can have bleeding at the same time. Unfortunately, some patients, a very small amount of patients out of the millions that were vaccinated, develop these blood clots in their brain. And there have been associated deaths with this complication. However, it is exceedingly rare. Usually patients will develop, I think it's about 3 weeks after, it's 3 weeks after the injection, the one and done. Patients can get headaches, blurry vision, fainting. They can lose control of a part of their body or develop seizures. Again, this is not to scare you, it's to educate you. This is a well-established and well-known phenomenon in the medical community. So myocarditis is the hot topic now in the news. Everyone's talking about the myocarditis that's happening associated with the mRNA vaccines. I read that it is more common in Moderna compared to Pfizer, but it has been associated with both. And the take-home point here, again, is that these vaccines are highly efficacious against preventing coronavirus, preventing the need for hospitalization, and also preventing a death from COVID. So what's happening here is that these patients are developing an inflammation in their heart. And we see this with viral infections, and we see this with COVID also. So it's not just the vaccines that can cause this, but we are seeing it in men under 30 years old in most of these cases. And it's very rare. And 79% have fully recovered, and 9 have been hospitalized, and 2 have been in the ICU. So it's important, I think, to look at the data here. Out of 300 million doses given as of June 11th, this is a very rare event. And the take home here is that this is a treatable situation and very, very, very unlikely to end in hospitalization or death. So this is just a depiction of cardiac muscle or heart muscle. Not only can it cause myocarditis, but it can also cause something called pericarditis, which is just inflammation of the sac around the heart. And that is also exceedingly rare. So what are the side effects that we should really expect from COVID vaccines? What are we going to see in ourselves? And I know Dr. Zivin-Tutela and myself have experienced these in varying degrees after our COVID vaccines several months ago. So body aches, headache, fever or chills, soreness in the site of the injection, fatigue. Also something that got a lot of media attention was swollen lymph nodes, typically in the armpit of the site of the injection. And this is known to change a mammogram. So it's important to change what the radiologists are looking at on the mammogram. So it's very important that if you're going for a mammogram that you share with a mammography clinic that you recently had a COVID vaccine and what arm you had that vaccine in. It's important to note that loss of taste or smell or cough are not side effects of vaccines and are concerning signs and symptoms of COVID-19. And if patients have that, they should isolate and get tested. So I wanted to really go into the very specific COVID-19 vaccine myths. So a common myth is that a COVID vaccine can cause a false positive COVID test after my vaccination. And this is false. And the reason why this is false is because no COVID vaccine has live virus. These vaccines do not contain any live viral particles and will not trigger a false positive COVID test. I'm pregnant, so it's not a good idea to have a COVID vaccine. And I'm just going to skip to this to show you what the CDC and the FDA are doing to ensure that COVID vaccines are safe in pregnancy. This is not to read right now. However, if you're interested, you can go through and read this. And there's also a link to the CDC at the end of the talk. But basically, pregnant women, as we know, have been classified as a vulnerable group to severe disease from COVID-19. I know Dr. Zivin-Tutela has treated many COVID patients who are pregnant, and unfortunately, they didn't do very well. So, when I say that they're vulnerable to severe disease, that means that they have an increased risk of hospitalization and death. So I looked when I was preparing this talk and to give you the most updated guidance here, as of June 14th, over 124,000 vaccinated pregnant women have been followed by the CDC. And to date, what they have found from these studies is that these vaccines are safe in pregnancy. And the take-home point, and if you remember anything from this entire talk, is that the benefits outweigh the risks. So another myth is that COVID vaccines can cause infertility. What I want to say here is that I think it's very important for people. I learned this in college, but more so in medical school. It's important to know what your sources are. You can literally Google anything and find something to back something up, but you have to understand where your data is coming from. So COVID vaccines available in the United States have not been associated with infertility. And this all came from a false report that surfaced on social media saying that the spike protein on the coronavirus was the same as another spike protein that's involved in the growth and attachment of the placenta in pregnancy. The false report said that getting the COVID-19 vaccine would cause a woman's body to fight this different spike protein and affect her fertility. These two proteins are completely different, and these COVID vaccines are not going to impact fertility is the take-home point, okay? But any pregnant woman should definitely discuss the risks and benefits with their provider, okay? Another one that I heard actually from my little brother who didn't want to get a COVID vaccine is that COVID vaccines cause cancer. So there is no data to date in the medical literature that suggests that COVID vaccines can cause cancer. This is obviously something that is an important topic and is being studied. However, there's nothing to suggest that this would do this, and there's no mechanism to support how this would occur. A common one that I've been asked actually from many companies that we work with is that the COVID vaccines contained fetal cells and fetal tissue. The COVID vaccines do not contain fetal cells or fetal tissue. Moderna and Pfizer both perform tests to ensure the vaccines work using fetal cell lines. So fetal cell lines are cells that grow in the laboratory, and these cells were initially taken from elective abortions in the 70s and 80s. Johnson & Johnson also used fetal cell lines in the development of their vaccine and the conformation, the production of their vaccine, but their vaccines do not contain fetal cells or fetal tissue. And these current fetal cell lines are thousands of generations removed from the original fetal tissue, and they do not contain any tissue from a fetus. I have already had COVID, so I don't need the vaccine. This is another one that I've heard a lot. So people who have gotten sick with COVID may still benefit from getting vaccinated. There's not enough information currently available to say if for how long people are protected from getting COVID after they've had it. That's a natural immunity. But early evidence does suggest that natural immunity from COVID-19 may not last very long. So the take home here is that an immunity from a vaccine is more robust than natural immunity. Okay, and recent data was just published. Actually, I think it was this morning or yesterday in Nature, which is a medical journal, that shows that the mRNA vaccines look like they're going to be protective for potentially years. But we're learning more, and obviously that can change at any time. So COVID vaccines were rushed, so they cannot be trusted. And honestly, before I knew all of the things on this slide, I felt that way also. And I was a little hesitant initially. And then I did my research and I read. So COVID vaccines, the mRNA vaccines, were created with a method that's been in development for years. A lot of people think that this is brand new and it's never been used before, but these mRNA vaccines have been used, have been studied for decades, okay? So these companies were really ready to go very early on in the pandemic. China also isolated and shared the genetic virus information so we could start working on these vaccines. And the vaccine developers didn't skip any testing steps, but what they did is they had the funding to be able to do the steps simultaneously instead of in tandem, which is what typically happens. So not only did the government put in a lot of money to back these studies, but they were also funded privately by different investment companies and private investors. So also what we have now, as we all know, is social media, and that helped greatly in collecting data and actually enrolling patients in clinical trials. So we were able to reach out to the communities and get people to come in for the clinical trials, which really sped up the studies. Because obviously COVID-19 is so contagious and widespread, it did not take long to see if the vaccine worked for the study volunteers who were vaccinated. You can imagine if you're studying something that's more rare, it's much more difficult to get patients and complete these studies in a timely manner. And companies began making these vaccines early in the process, even before FDA authorization. So they were really ready to go once they had their approval. Another myth, which changed recently in May. So once I'm fully vaccinated, I must continue to wear a mask. And I want to say that this topic is dynamic, right? Because COVID is. So this guidance can change, just like all of the guidance that we talk about, okay? But as of May 13th, the CDC updated their guidance, and they said that fully vaccinated people can resume activities without wearing a mask or physically distancing, except where required by federal, state, local, tribal, or territorial rules, regulations, laws, including local businesses and workplace guidance, okay? an important message here is that if you have a condition such as you're immunosuppressed from an organ transplant, or you have an underlying cancer, or you take medications for Crohn's disease, it suppresses your immune system, or psoriasis, you may not be fully protected even if you are fully vaccinated. Okay, so I would talk to your healthcare provider, and you should really consider continuing to mask because we just don't have that information yet in terms of whether or not you're protected. So another common myth is that you can get COVID-19 from a COVID vaccine, and you cannot. And that's the same reason why you can't trigger a false positive COVID test, is because these don't contain live viruses. So COVID-19 vaccine side effects are dangerous. So we did talk about the very, very rare side effects, but most of the side effects that we are going to see in our community, in our schools, are very mild, low-grade fevers. Some people can get higher fevers, but the main side effects are not going to be very dangerous at all. Something that I heard very early on when the vaccines came out is that the COVID vaccine enters your cells and can change your DNA. And I've had patients call and ask me that specifically, and that's not true. Okay, so the 2 mRNA COVID vaccines basically do not enter your cells at all. They enter the cells at all, but they do not enter the nucleus, and the nucleus is where your DNA resides. So once the COVID vaccine enters your body, it generates your immune response, and then it's gone. It doesn't hang around, linger in your cells, and it definitely does not enter your DNA. So that's very important to understand. And this is something I briefly touched on before, that the mRNA vaccine technology is new. So like I said before, this type of vaccine has been in development for decades. So this is not new technology. We are using it now for the first time on a mass scale, but this is not new technology. The CDC can mandate that I get a COVID vaccine. So that is not something that the CDC can do. The federal government does not mandate vaccination for people. Your schools or businesses can do that, okay? So that's something to keep in mind. A lot of people call and say, well, I got my first COVID vaccine and I felt terrible after it, so I'm not going to go get my second one. And the myth here is that you don't need a second one because you're fine. But that's not true. To get to the 94-95% efficacy with mRNA vaccines, you have to come back for the second dose, okay? You're really asking for it, I would say. You're asking for a potential infection if you are not fully vaccinated. Additionally, you cannot technically operate in the communities like a fully vaccinated person. So that's another incentive to get fully vaccinated. The only people who should not get both vaccines is if you had an anaphylactic reaction or a severe allergic reaction to the first dose. And then you should speak to your doctor, obviously, about what to do from there. So this is myself and Dr. Chutella getting our first COVID vaccines. We were very excited and happy to have done that. And I can share that after my second dose, I was in bed. I had a fever to almost 102, and I had body aches and a headache. And then a day later, it was gone. And I'm grateful for that, had that opportunity to get a Moderna vaccine. And I think, Dr. Chutella, I don't know if you got Pfizer or Moderna, but if you want to share how you felt after your vaccine, I know you had a little bit of a harder time than I did.
Yeah, sure. So I received Pfizer, so we're a good pair. We each got different ones, and I had a little bit higher grade fever and chills and some nausea, and really kind of felt beat up for about less than 24 hours. But since I was as you were, one of the first people to get vaccinated as a healthcare worker, I was documenting on social media my experience because I was actually thrilled that I felt so bad, because that meant my immune response was appropriate. I had lots of physicians and nurses and other healthcare providers who were reaching out to me when they didn't have all those symptoms and were concerned they actually didn't have that they weren't protected. But not everybody has the same response. I was grateful for mine. I felt, bad for about 24 hours, and then I was back to normal. So by far better than any of the true COVID infection that I could have gotten without vaccine.
Thank you. So these are the references that I used to put this talk together. If anyone has any interest in looking up anything further, that is all there. And we can take any questions.
Well, first, thanks very much, Doctors Lerman and Zivin-Tutela, for that presentation. Really appreciate the time that went into that. We had some questions sent into our Jasper's Return at manhattan.edu account, which is kind of our catch-all account for any inquiries for our One Manhattan campaign, and our return to a fuller semester in fall of 2021 than we had last academic year. So we did receive a few questions. Some questions that we received you touched on already, but one that we've seen frequently is the question about younger people, specifically college-age students, and essentially why should they be vaccinated? I don't know if I've seen exact data as to the percentage of hospitalization or deaths among college students. But what would you say to a college student, who might feel that, there's not a huge risk in contracting COVID and is questioning why they should be vaccinated?
I'm happy to jump on this one if you want, since you've been talking for the last half hour. So this question is a valid question. It's come to me from a lot of people from as young as the 12 and up age up through high school and college. And yes, the risk of hospitalization and death is lower in that age group, even as college students. Although college students approach the same risk as older adults in their risk of hospitalization and death. But the real reason to get vaccinated, in my opinion, and one of the reasons I vaccinated my 14-year-old, is the risks that come along with COVID infection, which a lot of people have heard about, this long COVID syndrome. And this is various different residual side effects, from chronic headaches, to lethargy, to fatigue, to being inattentive. And we have seen this pretty significantly now, since we have more experience in this pandemic. And this can go on for months and months. And a lot, on average, it's about 3 to 6 months of having these lingering side effects. So if you think of a college student who's in the best time of their life, in college, having fun, living their best life, having chronic headaches, being inattentive for class, just not having energy to get up and go to class, is actually a big deal. I feel that way through all of the education ages. So, from elementary up, it really can change your trajectory of learning and education and what you do in the future. So I think that's one of the big reasons to get vaccinated, is to not have that issue with these long haul chronic issues. There's other things besides death and that occur with COVID. And I can tell you, a great example is I had a young person who was 19 who had a very mild disease in December. And she's just one example, but she had a very mild disease, went back into her normal world when she was out of her quarantine time, and about 6 weeks later presented to the hospital incredibly sick, and had such inflammation of her heart and dysfunction of her heart that it is now 6 months later, and she has not regained normal function of her heart, and it has dramatically affected her life. And she's one example, but I have several of those. She's just my most recent. And that's reason enough to go ahead and in my opinion, assess that risk-benefit ratio of vaccine versus disease?
Thank you, Tracy. I just want to add, can I just add to that briefly, Pete? So I completely agree with Tracy, obviously, and I had a similar case to her when actually we were in California together of a young boy who was in his early 20s who came in severely ill months after having coronavirus. He had that MIS-C condition. So that I feel strongly about. That obviously it's a more rare event, but I also think it's very important to understand that we need as much of the population vaccinated as possible to control over this virus. So if we have 50% of our population unvaccinated, you have 50% of our patients who are still being admitted to the hospital, still dying of coronavirus, right? We know that almost 99% of the patients admitted to the hospital now are unvaccinated. Okay, so this is obviously a very real thing. Plus, what we don't want to happen is that these, if COVID is still out in the community like it is, it can continue to mutate, okay? And what we don't want to happen is that it mutates to a point where Moderna, Pfizer, J&J are no longer effective, right? And then we have to start the whole thing over again. So it's really a race between vaccine and variant. That's what we're dealing with.
And I'll only chime in on that is the information on the Delta variant out of India is the greatest affected were 20 to 40-year-olds. It was hitting a much younger population, and in the places in the U.S. right now where we have a significant increase in Delta variant and an increase in hospitalizations, it's in the younger population. It's in the 20 to 40s.
One question we had kind of follows the conversation you've had about discussing risks and benefits with your with your patients. Are there any pre-existing conditions a person might have where you wouldn't advise them to be vaccinated? And how would you speak to them about that?
We're racing to answer. You could go, Tracy.
So the only one is anaphylaxis. So if they had one vaccine and had a severe allergic reaction, then we don't give them the second, and then we actually, from a medical perspective, discuss giving a completely different vaccine depending on their risk factors. So there is no true contraindication other than a severe allergic reaction.
Thank you. Another question that we've seen frequently is the question about the emergency use authorization and why these vaccines are not fully authorized, and the question about when that might happen. Do you have any insight you could provide there?
I'll be happy to chime in again. So in early May, Pfizer applied for FDA authorization. In June 1st, Moderna did apply for FDA authorization. As of the news, literally in the infectious disease world and medical world, as of even this morning, everyone's kind of, stomping their feet and saying, where's the meeting? What's going on? There's tons of data. Why has it not happened yet? So I think it will happen. They are combing through the data. There is nobody that believes that it will not be FDA approved. There's more data on these vaccines in such a short amount of time than we've had collecting data on almost anything else. So it's in the paperwork is in at the FDA. They have not had a meeting yet. Dana, anything else?
Thank you. What's the likelihood if somebody has tested positive for COVID that they would test positive again? And I guess the question there, maybe implicitly is, I've had COVID, I have my natural immunity. Why do I need to be vaccinated? And I know, Dr. Lerman, you touched on that in your presentation, but is it possible to expand on the reasoning for that?
Sure. Reinfection is possible. We've seen it. It typically would happen 90 days after the initial infection. So we think that you have this relative degree of this natural immunity, but it doesn't last. It doesn't last beyond that time period, as far as we know. You know, we're continuing to look at that. I know that the CDC was considering extending that 90 days out, but they have not done that yet, right, Tracy? To the best of my knowledge, they have not changed that recommendation. So the issue is that you have this window, but beyond that, it's unknown. So that's why we recommend
and
getting
I'll
back.
just chime in that it's not a perfect window. 90 days isn't a magic number. I've seen someone reinfected at day 85, and I've seen, I've seen reinfection at obviously over 90 days. It's still rare to have reinfection, but with all the new variant strains, all these different, they've now been renamed alpha, beta, delta, but most commonly people know them as the Brazilian, the English, the Indian strain. We're trying to lead away from that in order to not kind of point fingers at where an origin is. But all those different strains now make you susceptible. You're still susceptible to a different variant strain. So as our strains are changing in the US, just because maybe you're infected 3 months ago, and at that time we had predominantly the alpha strain, now you're at risk because by next month we will have a predominant delta strain for sure.
And you mentioned reinfection. Can you also speak a little bit about spread? Especially if, say, someone's asymptomatic or something like that. Is there any difference in how they might be able to spread the virus, through one of these variants, or, if they had COVID? Is there anything any more information that you can provide there?
Yeah, we really don't have the information on, if you had a infection a few months ago and now you have a reinfection, are you more or less likely to transmit? Likely, it's probably the same. And I'm saying that just from a scientific mindset, but without data. If you were susceptible enough to get a new infection, you're probably transmitting at the same, at similar or the same. Now with vaccine, if you develop infection, what we call breakthrough infection, which we expect because no vaccine is 100%, the question is, will you, if you had vaccine and then got the infection, and we know that infection will be mild, will you still transmit? And on that front, the data looks like it would be a less likely transmission because you have less viral particles, but it's still not zero.
How have you spoken to parents, not only parents of college age students, but parents of 12 plus, who might be concerned about the effects of the vaccine on their children? Still unaware of the small percentage of risk, but how do you kind of talk to parents about weighing those risks?
I think it's important really to educate yourself. They have to educate themselves, right? So they have to become familiar with the information, and they have to use a trusted source. And it's important to understand, sure, there is this risk of myocarditis in younger people, right? We know that, right? Okay, well, what are the risks and what does that look like? What if my child was to develop myocarditis? When is that going to happen? What should I be looking out for? Just really educating them. And I think that once people learn that, out of the millions and millions of, I think it's 300 million doses, there's such a small number that it's happened in, is really a comforting thing. But also not only that, it's comforting to know that if your child does have myocarditis and for some reason they have to go to the doctor or the hospital, they're that sick that they're going to be okay, right? The deaths that have happened from that, I know 2 were in the ICU. I don't even know that anyone's died from it. So Tracy, do you know something different? Have you heard of a death? I haven't.
No, and the greater risk is the myocarditis from COVID infection. I mean, myocarditis happens with lots of different viruses, and we're in the summer months where spring and summer, we tend to see more myocarditis from other viral infections. And now that there's less mask wearing, we actually are seeing those infections, believe it or not. And so the risk, that I say to parents and to people to educate themselves is look at the risk of myocarditis or clotting from the infection itself is far greater risk than from the vaccine side effect.
Right. And I personally have a friend who's a surgeon who got coronavirus and then ended up having an arrhythmia from it and now has an internal defibrillator. I mean, that's just my own personal small little bubble of people that I know. So, I mean, it's real. The adverse effects that coronavirus itself will cause so far outweigh the adverse effects from a vaccine. For us, I know it's easy for us to sit here and say, oh, it's a no-brainer because we know the data, but people they have to educate themselves. They have to listen, they have to read, and they have to use a trusted source.
And I think we have a unique point of view because we actually take care of patients, right? So we see things and we have a different perspective. But when you look at the community, those who have had a family member or a friend who have been affected by COVID-19, those are the ones that are more likely to get vaccinated. So the ones who don't have a personal connection tend to kind of shy away from the vaccine. And I think it's important, as Dr. Lerman said, is for those to really educate themselves with trusted sources and really understand that the risk of vaccine, far outweighs any of the potential side effects.
Are there any approved medications or treatments currently being used against COVID-19? I know in the presentation you mentioned that there's no known cure, but there are things being used, if you do become ill. Can you speak a little bit about that and their success rates?
Happy to. So, steroids is one of our mainstay treatments in the hospital. It has been shown steroids, once someone has low oxygen levels, is very effective in preventing them from having to go onto ventilation or meaning into the ICU with a machine breathing for them, or death. Again, that is not recommended outside the hospital. That's recommended within the hospital. And there's parameters that we as physicians follow that. There's been approval through the FDA for another medicine that lowers your immune system when used. It's called tocilizumab for anyone who wants to Google it. And that's a medication that was approved in certain instances in the hospital as well as blood thinners. So there are different things we have. We have it for early in disease in hospitalized patients, but not early in the disease in the sense of people who are at home just kind of hanging out, not feeling well. We don't really have much to offer right in those patients. We do have some monoclonal antibodies infusions that are an option, which are actually, unfortunately, even as of this morning, getting more resistant to these variant strains. So we are starting to lose that pre-hospital treatment option that we did have for our most vulnerable population. But there's lots of things that are still being investigated and looked at. So as we've gone from 15 months ago of having really nothing, we definitely have more things on our plate to use now than we did more than a year ago.
Did we say remdesivir, Tracy?
Oh, sorry, remdesivir. Yes, I'm sorry. Go ahead, Doctor. Sorry.
So very early on in the pandemic, we were able to access a medication called remdesivir, which is an antiviral agent that we're still using today for patients. And it has been used as an anti-Ebola medication, actually, previous to its use with coronavirus. But it's very interesting how the therapies for COVID have really changed over the course of the pandemic, because, very early on, we were told from the CDC to not use steroids. That do not use steroids no matter what, unless the patient had this very specific issue. And now all of our patients are on steroids. Also, early on in the pandemic, we were using hydroxychloroquine, and we do not use that anymore. So it's very interesting. A lot of people email us and ask us, well, what about ivermectin? That's also not a recommended therapy. It never was, actually, but there are still some providers who use it. There are some providers who use colchicine. We try to stick with the guidance from the Infectious Disease Society of America. They have very clear guidance on how to treat our patients. Unfortunately, in the beginning of the pandemic, we had very minimal guidance, and we were practicing pandemic medicine, because it was a time where our patients were dying and we didn't know what to do for them. So we were really just hanging on to small studies out of China, little shreds of evidence, and providing that to our patients because we didn't know what else to do.
That's helpful. Thank you both for sharing that. One last question. We're coming up at the hour mark here. Do you foresee a need for people who have been vaccinated to receive booster shots at any point? I believe in the presentation you mentioned that there's still studies being done as to how long immunity might last, but could you speak at all to potential need for a booster shot?
Sure. I think that it's possible. I think it's important to understand and remember that this is a very dynamic process, right? So it's possible that the recommendations come out that says, if you got Johnson & Johnson, you now should go for a Moderna and Pfizer, based on the variants and how things change. That's possible, okay? It's also possible that we get variants that develop that our vaccines, all of them, are not going to work for. It's possible. So that would require another dose or a change in the vaccine to target those variants. And in terms of the recent data from the Nature article, it does suggest that it's possible that mRNA vaccines might have long-lasting efficacy, actually years. So I think just the jury's still out on all of that. No one is recommending it at this time, but there's a lot of chatter all over in the medical community and in the media about that potential.
The only thing I'll also chime in is there is some evidence that those with certain immunocompromising diseases, such as organ transplant, some other medications, there are ongoing studies about giving a booster in them because they don't mount the same response after the 2 mRNA. The jury is still out, but that is an ongoing current study that we will have information from soon. So again, if you're someone with a immune compromising disease or disorder, talking to your physician fairly regularly would be my recommendation.
Thank you. And last thing, just wanted to offer the opportunity for maybe one quick takeaway that you'd want people watching this to to hang on to going forward.
Sure. I'll just say, kind of this same thing I've been saying all along, is that this is a risk-benefit analysis, but also it's not just about you, right? It's about your grandmother. It's about your younger sister or brother. It is about the entire community, and not just the community, but the world, right? And not every country has access to vaccines, and we are privileged beyond belief. And it's sad for us to see what's going on in countries like India and the Philippines and Vietnam, who don't have the privilege that we have. It's sad for us to see that this is all about education, because if you can get educated and you understand the real data and the real facts of what we know so far, there's no reason to not get a vaccine.
Thank you. Really appreciate both of your time and your discussion here today. For the Manhattan College folks, if you do have any questions going forward about COVID-19 vaccine for students, I'd suggest that you reach out to health services. They can be reached at health.services@manhattan.edu. Or you can call 718-862-7217. For employees, you could also reach out to the Human Resources Office. They can be reached at human resources, all one word, @manhattan.edu. And Drs. Lerman and Zivin-Tutela, thank you very much for joining us here today. We really appreciate your time, and thank you again.
Thanks for having us.
It's been
Thank
our
you.
pleasure.